Hello, future nurses. It is Julie here. I am going to be doing the first half of your Unit 4 lecture since you will not be in class on Thursday. So, just a quick overview because I've added a bunch of stuff to the Unit 4 module. So, one of the things is this RN anxiety table. This is what's going to get you credit for listening to the lecture. And honestly, it's essentially a note sheet. So, this right here talks about the different levels of anxiety: mild, moderate, severe, and panic. And what I'm asking you to kind of identify just here is that level of anxiety normal? What things are you going to see if you're going to be assessing your patient? How can you tell looking at them or listening to them to describe it? That's subjective and objective data. What will you see with each level? And then the interventions. What are some things to keep in mind, right? Because honestly, I'm going to give you the hint. Mild, we're probably not going to do anything. But panic, we're going to have a lot more that we might have to do and consider. The second page just talks about some different disorders: generalized anxiety disorder, panic disorder, OCD, and a specific phobia. I've left this one blank. There's a few other ones we touch on, but don't really go as in depth into. That one's kind of optional if you want to add anything into that column. And just a description, right? How are you going to remember what this is? What are you going to think of when you're assessing your patient? What are they going to have? What would be a potential nursing diagnosis for each one? And what is an intervention we're going to have to think of when we're working with this patient? So this is here. It is in the Unit 4 module. You will have to fill it out. I've added and let's actually publish this now. I have added a section for makeup work. So by Friday, right, end of class, you will have to go in and upload something to this October 26th makeup work assignment. It is pass-fail. There is not much more than that. Just upload something, this RN anxiety table, to it. We're going to be learning about defense mechanisms. I will post the answers to this, but it's always good to know how to identify the defense mechanisms. So usually I would have you do this in class together and we'd go through it. It's a bunch of different example scenarios. So as you look at each scenario, what defense mechanism do you think that the patient is using? And there are some that may have more than one answer, and that's okay. On Friday, I will post the answers to that. And the Holmes Life Stress Inventory and the Coping Strategy List and Worksheet are more some just some like FYI fun stuff that, at least to me, it's fun, that we're going to talk about during the lecture. So that's what you can find in the Canvas course. So for our lecture, Unit 4, we're discussing and starting on stress and anxiety. So Chapter 10 is stress responses and stress management. So we have some theories related to stress. And honestly, some of these you probably already know about. Fight or flight has historically been if you see a tiger. Are you going to fight the tiger or are you going to run away from the tiger? How does an individual see and perceive the threat? And how do they survive? Freeze was added in at some point. I honestly don't know when. You don't know whether to fight or flight, right? You don't know what to do. You are so overwhelmed and you are so stressed that you just freeze. You cannot make a decision. And some people criticize this theory as being super simplistic, that there's more to it than that. But we're kind of going to take it as it is and see. General adaptation syndrome was kind of an expanded theory of Cannon's fight or flight. And in this, our patients go, or us, it could be anyone really, goes through 3 different stages. The alarm stage is the initial brief adaptive response, that fight or flight or freeze, to the stressor. And it begins with sending the information to the brain's amygdala, which processes a lot of your emotional data. It interprets, right, that amygdala, the event as dangerous, and it sounds an alarm to your hypothalamus. The hypothalamus responds in one of 2 ways. It could signal our autonomic nervous system. Signals, you could tell, sorry, it is Sunday night. Signals autonomic nerves to the adrenal glands, which pumps out adrenaline, which activates the sympathetic nervous system, which results in, right, faster heart rate, increased blood pressure, our breathing, more oxygen sent to the brain, right? Pupils dilate so we can see more. Glucose gets pumped to the bloodstream, which helps give extra energy. Blood actually goes away from our digestive tract, why we get dry mouth. And honestly, this happens like so instantaneous that some of us are not even fully aware of the scope of the threat yet. After that initial surge of epinephrine subsides, our HPA, hypothalamic pituitary adrenal axis, which is your hypothalamus, your pituitary, and your adrenal glands, is activated. And that's kind of like the gas pedal of the system that keeps the system in high alert. The hypothalamus secretes a hormone that goes into the bloodstream to the adrenal cortex. The adrenal cortex then produces extra cortisol to increase blood glucose and muscle endurance. At the same time, other non-essential functions are decreased. I don't know if any of you have ever realized, like if you were in a situation and it's like super dangerous at first, once you can kind of come down, you're like, oh my gosh, I have to go to the bathroom. That's because our body isn't focused on our bladder, because we don't necessarily need our bladder to live. Our body's trying to protect a lot of those major organs, right? Our brain, our heart help us think. If the threat subsides, the body rests and the stress response system subsides. If the threat continues, we enter the resistance stage. And in the resistance stage, it's when we continue to try to resist the stressor. Usually, we can successfully overcome. Recovery, repair, renewal may occur. We may have used up, right, our energy, our resources to defend ourselves against the stressor. If the stressor continues and the body remains in a state of arousal, we enter the final stage. Because we have used so many of our resources, we enter exhaustion. And this occurs when all attempts to resist the stressor prove futile. We have no resources, the stress becomes chronic, and the impact of long-term overexposure to cortisol renders people more vulnerable to illness. And I know that's a whole lot of words to sum, and the kind of neurobiology to sum up a lot of this. So we have that alarm stage. Something happens. Sympathetic nervous system gets working, and it continues to work. And our body is releasing cortisol, it's releasing glucose to try to help us be able to fight, to think clearly. And cortisol in large amounts is really bad, which is why we wind up in that exhaustion stage, why we see more other illnesses in individuals who've been under periods of prolonged stress.
stress levels so that we're not chronically stressed. Things like social support, exercise, finding a hobby, and maintaining a good balance of stress in order to function at our best. To accomplish this, we're incorporating appropriate time management.
Okay. So, following up on that, we have two types of stress that we and our patients will experience. Distress is the word we're probably most familiar with, and that's that negative stress, right? The one where you have a death in the family or tons of schoolwork, right? Maybe financial problems. Stress still can tax your system. It still can cause some of the physical reactions, right? The birth of a child, going on vacation. I honestly love Christmas, but I find Christmas to me is eustress. Having to go shopping and wrap all the presents. I don't know about y'all, I'm up till like 2 in the morning on Christmas Eve, Christmas morning, wrapping presents, right? It makes me happy, but I'm exhausted from it. So we have to balance both of these. And we're going to do an activity. I'm going to have you kind of take a look at an activity that helps you kind of see how distress and eustress affect the system. So, neurotransmitters in stress, serotonin synthesis. We see more active serotonin. And from your previous lectures, you know serotonin, mood, sleep, sexuality, appetite, aggression, metabolism. It's even one of our main neurotransmitters implicated in depression. During times of stress, serotonin production becomes more active. This stress activated turnover of serotonin is mediated by corticosteroids. Research believes this activation may dysregulate or impair serotonin receptor sites and the brain's ability to use serotonin. So we see a whole lot of different implications. Our immune system stress response. Research have found evidence that stress can induce changes in the immune system, malfunctions in the immune system, right? Autoimmune disorders, immunodeficiency, hypersensitivity. And there are so many complex ways that stress influences the immune system. So we can't necessarily pinpoint just one. At least in this class, we're not going there. So mediators of the stress response. What are things that causes or helps with stress? So we have two different types of stressors, physical and psychological. Physical stressors could include trauma, excessive cold or heat, hunger, pain, right? Hemorrhaging blood, infection. Psychological stressors are the ones I think you tend to think more about when we talk about mental health, right? Divorce, loss of a job, death of a loved one, retirement, right? We think retirement's a positive, but for some people, it's such a big change. It's a stressor, right? And then that eustress, marriage, new babies, an unexpected success. If you go win the whatever that really big lotto is that they always say is like $2 billion, right? Winning $2 billion is going to be something that's positive. However, now you have to figure out how to manage the money. So that also is a stressor. Perception is how we see the stressor. All of us are going to have different opinions of something that is stressful. Something that is stressful to me might not be stressful to you, and vice versa. Temperament, it's based on individuals' perceptions, which we see genetics come into play, vulnerability, childhood experiences, coping strategies, outlook. It's a kind of big tied together present bow of who we are. Our social supports, we will talk a lot about support groups in this class. And if someone has strong support, right, from their significant other, from their family, from friends, that enhances their mental and physical health and can act as a buffer against distress. Culture. Each culture emphasizes certain problems of living more than others, but also interprets emotional problems differently. And then spirituality and religion. Help people cope with stress. Most religions promote hope and optimism. Having a religion, belonging to any religion, is a protective factor for suicide, in part because if you belong to a religious community and you're active in it, you have a built in support system in most circumstances. So, how does nursing management and stress response all tie together? So, as nurses, we need to be able to measure stress. And the one we're going to talk about is our social readjustment scale, known as the home scale. And this kind of looks at it's the recent life changes questionnaire. I'm going to go ahead and switch over to it so you can see. And what the homes, maybe if it'll let me switch it over. Sorry, y'all, I got a dual monitor and I'm at home and it's different than there and it is not letting me. There we go. I don't know why it wouldn't let me. So this is the Holmes Life Stress Inventory. And what this does is look at during the previous year, what stressors have you had? And again, right, some of them could be considered positive. We normally think of marriage as something that is happy, but it's a change still. And the same thing, right? Pregnancy, birth, right? Adoption. Some of those can go both ways. I always love in-law troubles, right? Have you had any personal achievements? Changing schools, right? New homes. So you can see there's a whole lot of different things that can kind of go into play. You add up your total. 150 or less, right? Low amount of life change, low susceptibility to stress-induced health breakdown. 150 to 300 is kind of that, hey, we got to look at what's going on. Over 300 raises your odds of having a stress-induced health problem by 80%. So usually I'd ask y'all to do this, right? Let us know your numbers. Y'all can kind of do it on your own if it is something you're interested in and kind of see where you stand in it all. So, but when y'all do this, or if you do this, we have to remember that not all events are perceived to have the same degree of intensity or disruptiveness to everyone. Culture will play a role, right? And different people have different thresholds. So in that nursing management of stress, we have a few different coping styles, right? Health sustaining habits, medical compliance. Do you go to the doctor? Do you have a proper diet? Do you do any type of relaxation techniques, right? Life satisfaction. Do you like your work? Do you like your family, right? Hobbies, humor, nature. Do you have social supports, right? I always joke you have to have that friend who's going to help you bury a body. Who can you turn to? And then we have to look at how we respond to stress. Is it healthy? When we talk about coping skills, we have adaptive and maladaptive coping skills. And some kind of play on the line. I usually would ask all of y'all to tell me. So think about this, right? What are your coping skills? What do you do to help you cope? And some students, always like to joke drinking, right? When we bring up alcohol, and we talk about alcohol a lot in this class when we get to especially to substance abuse. Having a glass of wine at the end of the day could be considered adaptive because it's not bad. You're staying within the prescribed, limits of what is acceptable drinking. But if we have a patient who's drinking a fifth of whiskey every day and they can't go to sleep without it, that would be that maladaptive response. Shopping. Going shopping and buying yourself, one new thing when you're stressed. Not too bad. Maxing out your credit card, bad. So we have to kind of look and see where we and our patients fall in that. So relaxation techniques, biofeedback. In true biofeedback, you go to a clinic, they hook you up to all these wires and monitors. We're tracking your heart rate, we're tracking your breathing, your temperature, the amount of sweat on your skin. And then they're walking you through relaxation techniques and you're able to see what's happening to your blood pressure, what's happening to your heart rate, what's happening to your respirations as you do these relaxation techniques. So you can actually see how they're helping you. At the simplest, if you got like a smartwatch, your Fitbit, your Apple Watch, whatever, they usually have some type of biofeedback program on it where it's looking at your heart rate and it's like, breathe in, breathe out. And you can do it and see your heart rate lower on your watch. Deep breathing exercises, there's a whole bunch out there that we can do. I'll probably make you do one on Friday, kind of at home. I have worked with pediatric patients, and we even do one about blowing out candles on a birthday cake, because you can't tell kids to take a deep breath in, take a deep breath out. So you pretend you have a birthday cake in front of you, and you blow out the candles on your birthday cake, or hold a hot chocolate in your hand, and it's too hot to drink, so we have to breathe in and gently blow out to cool down the hot chocolate. So there's a few different things with deep breathing that you can do to make it a little bit more fun. Guided imagery, right? Close your eyes, pretend you're on a beach, feel the sand between your toes, hear the waves, feel the sun on your skin, right? Talking our patients through a calming scenario. Progressive relaxation, one of the ones we see with that is progressive muscle relaxation. Um, Squeeze your toes as hard as you can and then release them. Squeeze your feet as much as you can and then release it. And you slowly move up your body, tightening all your muscle groups and then relax. And you feel, once you go through, if you've never done this, you can, I can put one in the module. There are some good ones that you can do, or even just Google to listen to, and you go through and you listen it, and it actually is really relaxation. Meditation, I'm probably the worst person for meditation. It does help a lot of patients though, right? Having them maybe focus on something and go through, right? What are you thankful for today? Maybe some journals where every morning they're going to focus on something positive. Physical exercise is a great way to manage stress. When a patient's having a panic attack, we can't tell them to go running. However, usually what the recommendation is about 20 minutes of some type of activity every day can help, right? Increase our baseline, increase our tolerance for stress, make us more healthy overall. And it could be as simple as going for a walk. Cognitive reframing is one of my favorites. And in cognitive reframing, what we do is we take a negative thought and we turn it into a positive thought. So at the simplest, I was teaching my 8-year-old how to rollerblade. And we went with straight rollerblades. We skipped the 4x4s and went to the blades. And he was like, I'm never going to learn this. I'm the worst rollerblader ever. But it was the very first day he turned them on and he went straight to, I will never get this. And he got stuck in that I can't do it. So in cognitive reframing, you change this thought. This is my first time rollerblading. With practice, I will get better. And we change that negative thought to a positive. Journaling kind of just is what it is. And then humor. Humor always works, at least for me. You could usually find something to help your patients, break through too. So, chapter 15, we go into our anxiety and our obsessive compulsive disorders. So, what is anxiety? It's an apprehension, right? That uneasiness. Something bad is going to happen. I just know it, right? Anxiety is normal. We all need it to survive. It happens. It never, ever goes away, right? You will experience this your entire life. And everyone, all of us have experienced it. Fear is that reaction to a specific danger. So if it's like there is a lion standing there staring at me, right? Fear. If I'm just afraid, right? And we'll talk about generalized anxiety disorder. If we're anxious about everything, and I don't know what's going to happen. It's nothing specific. I just worry. That is the anxiety. So our levels of anxiety, I'm going to quickly switch over to a different module table that we're going to use because I want y'all to take a look at that one instead. So this isn't a slide you have. This is not a slide you have, but I think it kind of is a good one. When we look at mental health, everything is on a continuum, right? Maladaptive panic, adaptive, right? Mild anxiety, anticipation. And when we have those 4 levels of anxiety, what we look at, what we see is the stable, right? And this table might help with that excitement that we're kind of doing to turn in. So, in mild anxiety, we might not know if we're looking at our patient, right? They are totally normal. They're calm. They're like, I may be a little uneasy, but there's nothing to tell, right? Perceptual field is broad. They're able to pay attention to what's going on around them, right? Their thoughts, random but controlled, which is honestly normal for most of us, right? We're going through life like nothing is wrong. Moderate anxiety, we can start to see slightly elevated vital signs. It won't be like our patient has 130 heart rate. It might be, well, their baseline at rest is 70 and their heart rate's 95, right? They could be more excited, right? Tense. Our perceptual field is narrowed because we are focused. We actually see, right, optimal state for problem solving and learning, right? You're worried, so you are focused on what's going on. You're able to pay attention. However, you're not, right, panicking. We're ready, we're challenged. Severe anxiety is where we start to see that fight or flight, where we see that autonomic nervous system come in, right? Our muscles, we're kind of like holding on to them. We're so tense. We see like back pain. Our senses aren't where they're supposed to be, right? We're not hearing everything. Our perceptual field is so narrowed that we don't know what's going on around us. We can't problem solve, right? Distortion of time. I once had a situation with my kid where we had to call an ambulance. And I was like, this lasted forever. And I was like, oh my gosh, everyone's dying. It was like the longest few minutes of my life while we waited for the ambulance. However, y'all, I'm right next to a fire station. It took them like 2 minutes to get here. But to me, it was like hours. What is taking them so long? Because I was in, right, this state of anxiety that I could not tell time like normal. Dissociative tendencies, when we talk about defense mechanisms, we'll talk about disassociation. We detach from what's going on, we daydream, right? We might see depression, we might see a need for space. We could see an increase or decrease in anxiety. Does our patient withdraw and freeze, or are they pacing, right? Becoming disorganized. Panic is what you think about with a panic attack, right? You will definitely be able to see this on your patient, right? They're may become pale, right? Blood pressure actually can decrease. They might be tachycardic. They might be hyperventilating, right? Pain, hearing is cut down. They have no ability to focus on anything around them. They cannot take any more stimuli. Their perception of unreality, they don't know where they are, right? And that disassociation, it is a very primitive defense mechanism. And we actually have a whole lecture on disassociation. Helpless, out of control, right? Disorganized. They could be sobbing, they could be pacing, they active, inactive, right? They might complain of like chest tightness, right? There is an elephant sitting in my chest. I cannot breathe. So we can kind of see that go a few different ways. Okay, so my table went into a little bit more detail. This is what y'all have about the anxiety levels. Good to remember, right? That super quick overview because it's always good to be able to tell the difference, right? Mild anxiety, slight discomfort, right? Maybe they're fidgeting a little, right? Moderate, your thinking is hampered, right? Selective inattention. It's going to vary. We start to see that stress happen. Severe, right? Perceptual field, somatic symptoms. And the somatic symptoms that your kind of PowerPoint references in anxiety, headache, nausea, dizziness, insomnia, right? Trembling, the feeling of like I can feel my heart beating in my chest, right? That hyperventilation, impending doom or dread. So defense mechanisms against anxiety. These are Freudian type things, right? Freud says defense mechanisms are something that our unconscious does to help us cope with stress or anxiety and to help us lessen the negative impact of it. Um, they can be healthy or unhealthy. We got this huge table of different defense mechanisms. The activity that I posted in Canvas will be really helpful to go through. I'm going to switch over and pop up. So I just realized, and I don't know where we are in this video, that every time I play a video, y'all can't hear the sound. I think I was able to go back and edit this to take out me switching to a YouTube video. So if it sounds weird, that is why. I'm going to post the link to the videos that I have. That way y'all can kind of watch them separately. Again, I would definitely check with that defense mechanism video. We need to be able to tell the difference between all of them. So, anxiety disorders. As we go through this, right, we're going to talk about a few different things that go along with it, right? The epidemiology of some of them, some of the comorbidities that we see, substance use. Substance abuse is a big one, right? Biology, genetics, a lot of those come into play with this. And we're going to kind of see through this. We tend to see anxiety disorders, right, clustered in families. First degree biological relatives of those with OCD or phobias have a higher frequency of these disorders than in the general population, right? The amygdala. It plays a role in anxiety and obsessive compulsives. And honestly, GABA. GABA is commonly the focus of pharmacological therapy for anxiety symptoms, right? GABA slows, it's an inhibitory neurotransmitter. It slows neuron activity, which plays a role in lowering anxiety. It's thought that people with too little GABA may suffer from anxiety disorders. So we have a bunch of theories, and a lot of these are going to be the same as when you just talked about the theories in general. So Freud, right? Freud suggested anxiety results when threatening repressed ideas or emotions are close to breaking through from the unconscious mind into the conscious mind. So we have something in our unconscious that we don't want to think about. And when it comes close to popping out into it, that's when we get anxiety. Henry Stack Sullivan, he linked anxiety to the emotional distress caused when early needs go unmet or disapproval is experienced. He suggested, this is an important one, that anxiety is contagious and it can be transmitted to the infant from the mother or caregiver. And we can take that a step forward, right? As nurses, as healthcare providers, we might have situations where we're anxious and we're experiencing anxiety when dealing with patients. Maybe there is some type of traumatic event or trauma at work. And we have to kind of keep our cool around our patients to keep them from getting anxious. Behavioral theorists, right? Behavioral theory tends to go with learned responses. So behavioral theorists suggest that anxiety is a learned response to a specific environmental stimulus. So a really good and easy example is if we were to go to class right on Friday, the next time I'm going to see y'all, and I'm like, take out pen and paper, here's a quick, added a Canvas quiz in, and I'm going to give you a pop quiz that is graded. You're going to be like, oh my gosh, pop quiz. I didn't watch the video. I kind of just half-assed my way through it. And you're going to get more anxious, right? There is a stimuli. I'm telling you there's a pop quiz that causes you to be anxious, right? Police, you're driving down the road and all of a sudden a police car is behind you, right? You're going to be at 10 and 2. You're going to be so focused because you're like, are they behind me just to be behind me? Are they behind me because they want to pull me over? That is that stimuli. Cognitive theorists believe that anxiety disorders are caused by distortions in the individual thoughts and perceptions. So when we talked about that cognitive reframing, right? Cognitive restructuring, you have the negative thoughts and you might see the world in black and white. And we need to look at what is the gray in between. Cultural considerations will always come into play. We've kind of already talked about it. It just, different cultures are going to find different things that are more stressful. So now we get into some of our fun things, right? What do we think about? I don't necessarily love how these PowerPoints are put together, so bear with me as we go through a lot of these. When we look at the anxiety, right, disorders, panic attacks, this is the one we're going to think most about. Most of our patients with anxiety aren't necessarily seen in clinical settings. They are going about their life, right? They're living, they're doing okay. However, panic attacks is one that we're going to see commonly, especially if we're in the emergency room. Is your patient coming into the emergency room because they're having a heart attack or because they're having a panic attack? And we can see some of the same symptoms, right? Your patient's trembling, they're short of breath, they're complaining like they're suffocating, right? And panic attacks are truly just an exacerbation of anxiety. And they can come from different things, right? There could be a specific trigger, or it could just come out of nowhere. So the panic attack is the specific event. Down here, you see this panic disorder. The panic disorder is when someone just starts having random panic attacks, or they're having multiple panic attacks. Especially in young kids, there might not be a trigger, right? This panic attack can just come out of nowhere. Um, and it really does have to do with that cortisol and the adrenaline. So we need to do a really good physical assessment on our patient who's having panic attacks, right? You cannot tell someone having a panic attack to calm down or take a deep breath, because in that moment, it's not going to help. When we talk about medications, right, our benzodiazepines are a great choice for a patient having a panic attack as long as it's not contraindicated. Benzodiazepines work well for pretty much everyone. But one of the biggest problems when we talk about the benzos is that they are short acting. They only work for a few hours. They're going to work super fast. If I go give you some Ativan, right, it's going to work in 15, 20 minutes and it's going to help calm you down. However, that's going to wear off after a few hours. So we really need to teach our patients some other things to help them cope while they're going through the panic attacks. We need to educate our patients, right? We don't want to take it all the time. Benzos have a high rates of addiction. High rates, and they're super horrible to get your patient to detox off of. So these truly are that PRN in case of an emergency medication. We want to talk to them, right? Don't drive, don't operate heavy machinery, don't drink alcohol. On their own, benzos don't decrease respirations, but when we combine benzos with alcohol or any other CNS depressants, that is when we see accidental death, accidental overdoses due to CNS depression. We also need to be careful of individuals who already have some kind of respiratory difficulties, COPD, sleep apnea, all of that with our benzos kind of can get tied into play. So it's kind of important to take a look at. Separation anxiety can be, right? We think of separation anxiety in kids, right? The first day you take your little one to preschool, they're going to be like, no, 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 don't leave me. And that is developmentally appropriate. When separation anxiety becomes inappropriate, if I have a 14-year-old who will not separate from mom, or a spouse, right? I have a wife who will not separate from her husband, and she starts to panic every time they separate. That is when it becomes a concern. And most of the time, if we're talking about, right, that separation anxiety disorder, we might see some trauma. If we have a 9-year-old who has been doing okay, and all of a sudden dad is like, I'm going to go run to the store and run some errands, dad is in a massive car accident, dad passes away. That child might struggle now to separate from mom because, well, when dad left, right, dad died. We do see, right, nightmares, right, jaw tension, grinding of the teeth in separation anxiety disorder. We want to talk to the kids about what's going on. If, I know you're not all going to be psych nurses, but sometimes if we have a kid who's in the hospital for a medical reason, we might want to explain to them, visitation hours, when the parents are coming, what's going on if the parents can't be there. Right? We can honestly, even with these patients, see a lot of GI upset. And for all of these disorders, we do have meds that work. However, we also want to get these patients into therapy. Agoraphobia. Agoraphobia is a fear of open spaces, right? Maybe you're somewhere and you can't escape. There is a video, I won't necessarily link to it because it's just a super short one. And there's just this lady talking, a clip from an assessment. And she's like, I went into the backyard yesterday and it was really hard. It could be maybe you have someone who never had agoraphobia and then something happened out in public, right? Behavioral theory. I was out in public and this happened. Maybe they were at, right? It's Welcome to America. They were at a concert and there was a mass shooting. And now they're like, I am safe at home. If I'm out in public, if I'm in this area, I can't escape. Something bad could happen. So they stay at home. Specific phobias. So there's a lot of phobias. And some of them, right, are more commonly known, right? Agoraphobia, right? Open spaces. Arachnophobia, spiders. Aerophobia, flying. And when we look at a phobia, it's a constant and irrational fear of something that causes the person to avoid that environment, object, being, whatever it may be. So when we look at our phobias, right, we are going to have someone who sometimes can go about life with no difficulties. If we have someone who's agoraphobia and they live in Alaska, not agoraphobia, someone with arachnophobia, right? Fear of spiders, and they live in Alaska. They might not have that many spiders hanging around, so it does not cause a problem. When we have someone who has a fear of driving, and they live in a suburb and they just have to drive places, right? It's going to affect their life, right? Someone who is afraid of needles and they're sick and have to be hospitalized. We have a few different ways to work with phobias, one being exposure therapy. And we basically just, in a supportive and controlled environment, expose the patient to what they're afraid of. We could do even virtual reality exposure, right? Here's a picture of a spider. Here's a, cute little fluffy spider. Let's watch the movie Charlotte's Web until eventually, I actually have a friend whose daughter has arachnophobia, and eventually they got a pet tarantula to help her overcome that phobia. Generalized anxiety disorder. Generalized anxiety disorder is difficult because this is someone who is constantly worried. They are worried 100% of the time. Everything worries them, right? It's beyond what is rational. And we, with this patient, see them fretting all the time, neck and jaw tension, loss of appetite, sleep at night when everything gets quiet. Their brain just keeps going and going and going and going. So they're so stressed out they can't sleep. High rates of substance abuse and generalized anxiety disorder due to self-medicating. GI upset, right? Irritable bowel syndrome type symptoms. We can see, right, if someone is, especially generalized anxiety disorder, we see it, is so anxious all of the time. That anxiety and elevated stress can lead to medical issues, right? Heart attack, right? MI, pulmonary embolisms. So we have to be mindful of someone with generalized anxiety disorder. There are some good meds for generalized anxiety disorder. I think we'll talk about it more when we get to depression. Our selective serotonin reuptake inhibitors. Some of our antidepressants, specifically the SSRIs, can help with anxiety. We can also see buspirone or Buspar come into play. So benzos would not be a choice for someone with generalized anxiety disorder because if they're anxious all the time, what are they going to do? Take benzos all day long. And they're going to take them and take them and take them. And eventually they're going to get to a point where they need more and more and more. And that's when we see that addiction to benzos come into play. So we really need to work at other things. Those patients with generalized anxiety disorder really do need therapy. Cognitive behavioral therapy is a good choice for them. Social anxiety and social anxiety disorder, there is this significant fear of being looked at by others with underlying fear, judgment, right? Opinions. So this is someone who it's like, I'm going to order online, ordering online was wonderful for those with social anxiety disorder because I can go and order my Starbucks drink online and just pick it up and I don't have to talk or say anything to anyone. Because if I had to go into Starbucks and order in person and I said the wrong thing, what if they ask me my name and I'm like, say something stupid? What if I'm at a restaurant ordering food and I mispronounce something and the waitress is going to laugh at me? And we see, just these thoughts with these social anxiety patients, right? Tremors, sweating. They avoid social events. We may give this patient anxiolytics. It really depends on what's going on. Again, therapy, all of our patients. It is never wrong to suggest a psych patient goes to therapy. Um, with social anxiety disorders, we may recommend they avoid caffeine, chocolate, excess sugar. That can help. We actually may even give this patient beta blockers. Propanolol is a wonderful choice of medication for someone with social anxiety disorder, even to take it PRN. I'm terrified of public speaking. I have to go speak in front of people. They can take a propanolol beforehand. It works very well. Other anxiety disorders, substance induced anxiety disorder. If we have someone who is constantly drinking alcohol, alcohol actually is an inhibitory, it's a depressant. And alcohol depresses GABA, right? GABA, we just learned, is tied into anxiety. So we could have someone who's normally not anxious. However, they're drinking, and the drinking leads to an increase in anxiety. It even could be medication based, like a prescribed medication. Anxiety due to a medical condition. If we have someone who has hyperthyroidism, hyperthyroidism can often look like anxiety and panic attacks, especially in women who tend to be in middle aged. So we need to be aware that the anxiety could have a secondary cause, right? A primary cause of anxiety would be I'm anxious just because I have true anxiety. A secondary cause of anxiety is I have hyperthyroidism, and the hyperthyroidism is causing it to present like anxiety. Obsessive compulsive disorders. OCD gets students confused, mainly just because you think of that colloquial, I'm really bad at pronunciation, guys. You'll learn that. What we think of is OCD. And you think OCD is your person who is nice and neat and organized. That is not always true. So a person with OCD has an obsession. They have this thought, this right impulse, something that gets into their mind, right? It's this intrusive thought. And it is in their mind and they cannot get it out. And that intrusive thought causes anxiety. And the patient wants to stop the thought from happening, but they don't know how, right? I'm having intrusive thoughts about germs. If I clean everything, I will ease my anxiety and the thoughts will go away. So, to ease those thoughts, the patient does this compulsion, right? A ritualistic behavior. And they can't not do the compulsion. And they're going to do it. And if I do this, it will decrease my anxiety. However, that only works temporarily. For many patients, this is a cycle that's going to repeat throughout the day. Probably 20 years ago, when I was in high school, I watched a documentary in a psychology class in high school on OCD, and it kind of stuck with me. I didn't know I was going to be a psych nurse back then, but I knew I wanted to be a nurse. And it was such a good example. I've been looking for it, but I cannot find this probably at this point 20, 30-year-old documentary. And it was people who had OCD, and there was a big segment of it to different types, right? We think about cleanliness, we think about germs as common things that we see with OCD. But these were individuals who they were driving down the road, and every time they drove over a bump, they got this intrusive thought of, oh my God, I just hit someone with my car and killed them. And they have this thought that's in their head of, oh my God, I just hit someone with my car and killed them. And they can't get that thought out of their head. So to get that thought out, they say, I'm going to stop my car and check. So they would stop every time they hit a bump in the road. They would pull over, get out of their car, look under their car to make sure they didn't hit anyone, get back in the car and drive. And then the next time they hit the bump, they would stop the car, get out of the car, check. And it could take them hours to drive somewhere. And if one important thing to remember with these patients, if we stop, if we do not let them compete their ritualistic behaviors, it increases their anxiety. So we have to be careful. We don't want the patients to stop the ritual. We want them to carry it out. However, we need to get them into therapy. right? Sometimes it's called exposure and response therapy, cognitive behavioral therapy, where they can slowly start reducing the amount of times. So if we have someone who does ritualistic hand washing and they have to wash their hands 10 times this way and 10 times this way and 10 times this way, what we want to do when we get them into therapy is to get it so they're washing their hands 7 times, then 5, then 4, and it would slowly go back. We have, I think you have some slides on it, a few different types of compulsive type disorders that we're going to go into. With these patients, if we're talking about like etiology, where does it come from? We tend to see childhood trauma and childhood abuse as kind of red flags. Again, that family history. If you have a family history of obsessive compulsive disorders, depression, additional anxiety disorders, and eating disorders all kind of come into play as what could be leading to it. And then I will put a link to this video because I've learned you're not going to hear it, or at least you're not going to hear it well. So different types of obsessive compulsive disorders. So OCD is the one we've kind of already just described. Your typical, I have this intrusive thought, I'm going to do this ritualistic action to decrease my anxiety. Other ones that we see, body dysmorphic disorder. And we tend to group body dysmorphic disorder with eating disorders, right? And classically, we're going to think someone with anorexia. Someone with anorexia is going to weigh, they're going to be 5'8" and weigh 95 pounds. And when they look in the mirror, they think they're overweight. However, body dysmorphic disorder could be, oh my gosh, look at my ears. My right ear looks different than my left ear, right? See how the pinna hangs down on my right ear? It looks so silly. Everyone's going to make fun of me. I need to go have plastic surgery to fix my ear. It could be the individuals who go through so many body modifications to make themselves look like a snake, tattoo my eyes, right? There's a guy who cut off his nose and split his tongue. It could come into that. Hoarding disorder. You have this obsessive thought of, I need this. And the thought of throwing it away creates such anxiety that you don't throw anything away. This is my kid's first, tooth. This is, my kid's favorite cereal. If I throw away the box, they're not going to get it. Hair pulling and skin picking disorders. Hair pulling by itself is called trichotillomania, and skin picking is called excoriation disorder. And in hair pulling, someone is anxious and unconsciously, without kind of any thought to it, they start pulling out their hair when they're having this period of anxiety and they can't stop. If you stop them from pulling out the hair, it increases their anxiety. So especially our trichotillomania patients, we're going to see bald spots. And I've even had patients who would shave their head and wear a wig so they didn't have any hair to pull anymore on their head. And then they move on to their eyelashes and eyebrows because they just can't stop it. Excoriation disorder, picking of the skin. Right? I know all of you are going to tell me, but I pick my cuticles or I do this. And right, that is normal. It's normal to at times, right, pick at our cuticles. These are people who, if I were to show, I have a few pictures, not in this PowerPoint, but elsewhere, the area around, right, their fingernails are just bloody. It's bleeding. They're having infections. So this is picking to the extreme. Other compulsive disorders, there could be a whole bunch. I wouldn't quite stress too much about the other. You could have someone who compulsively drinks water. Water intoxication is potentially deadly too. That kind of come into play. So our nursing process, I know we talked a lot about this last week, right? We have to do a general assessment of the symptoms. We have to look at the medical side of it too, right? That patient complaining of chest pain, though we're like, yeah, this guy has anxiety. There's a 99% chance it's anxiety. I'm not going to bet on that 1%. I have called 911 on plenty of old men who come to me complaining of chest pain, especially when I worked in addiction, to go get them a medical assessment because I was not betting on that 1% that, right, the 99. I don't want that patient to die on my shift. And just because, and I had a student one quarter, her husband was young. He went to the ER with chest pain and they were like, you're, 30, it's a panic attack, and dismissed him. They went to a different ER. Turns out he was having a heart attack. And I do know other people who've gone in and they've done the full cardiac workup for it's a heart attack. And it turns out it was just a panic attack. And I say just a panic attack, but they ruled it out. Our nursing diagnoses, again, are going to be what is the priority. So we can see suicide, right, in these patients if we have someone having a panic attack and they are past the point they just can't do it, right, and they're having maybe panic disorder, panic attacks all the time coming out of nowhere. Ineffective coping. Ineffective coping is a wonderful one for a lot of our anxiety disorders because, and even when we get to crisis next week, because your patient is not coping no matter what you do. They just can't do it. Outcome identification, again, is going to be on what is our nursing diagnosis. So if our patient is suicidal, our outcome is going to be, I want my patient to live at the simplest. If our patient we're dealing with ineffective coping, right? We're going to want a outcome identification is going to be, I want my patient to try 2 new coping skills today. And we're kind of going to backwards plan, right? What can we do for our patient? So again, I kind of talked about this a little bit already. I'm really bad sometimes about talking on those first slides. So do that physical exam. The source of the anxiety. Is it truly a panic attack? Or does your patient have hyperthyroidism? Right? Is it substance-induced anxiety? Assess for self-harm. We will always assess all of our patients for self-harm. The psychosocial assessment is really good because it can help identify different stressors in our patient. We're going to talk about, right, maybe in a psychosocial, housing, legal, family, job, school. And we can really see and get an idea of what's going on. And then we always have to do a self-assessment. Sometimes if we have someone who's really struggling and we're like, dude, today's not my day, I cannot be therapeutic. And I've had those days where I'm like, I do not care about your panic attack today. There's a lot going on. Or if we are anxious, is our patient causing anxiety in us? We have to be aware. Nursing diagnoses and outcome, again, right? Anxiety, ineffective coping, chronic low self-esteem. If we have someone with body dysmorphic disorder, trichotillomania, right? We're going to see low self-esteem. They're going to be self-conscious of the fact that they don't have hair on their face. Self-mutilation. Self-mutilation, I think y'all have talked about it already. Non-suicidal self-harm, cutting, which could be a way to cope with stress and anxiety, or it could be trichotillomania and excoriation disorder, right? And in that way, our outcome, we want the patient to practice self-restraint, which is harder than it sounds. Planning. A lot of our anxiety patients may not require admission. I have seen panic attack patients admitted. I've even seen a few OCD. But for the most part, as long as it's not affecting their life, right, they can stay out in the community. We want active participation, right? We want the patient to go to therapy, to be working on their coping skills. If we do have a severe level of anxiety, the patient may not be able to participate in planning. We may need help, right? If your patient cannot do their ADLs, they need to be inpatient. Again, more of the nursing process, implementation. What are you going to do, right? At mild, moderate levels of anxiety, at severe, at panic levels of anxiety. Counseling, sitting down and talking to the patient. And it does not have to be, extreme. It could just be what has worked for you in the past. That coping skill sheet that I put into the module, I'll flip to it at the end, is one that I would actually use with some of my adolescent patients. If help identify your trigger, help identify who you can call, what are some positive things you can say. Teamwork and safety, never ever approach a patient alone. And if you, right, promotion, along with promotion of self-care activities, if you're just not having it today, right, step away, let someone else come in. Sometimes it's really hard to work with anxious patients or honestly any psych patient. And we need to make sure we're taking care of ourselves. As we've gone through, I've talked a little bit about those pharmacological interventions. Antidepressants, especially our SSRIs, are going to be one of the ones we're going to use with anxiety patients. Anti-anxiety drugs, our benzodiazepines and our Buspar is another class that could be helpful. Other classes, honestly, a lot of non-psychiatric medications. We talked about a few of them, the propranolol for social phobias. I've even seen gabapentin. Usually, right, we use that for nerve pain. I've seen gabapentin, PRN for anxiety, or a standing order gabapentin for anxiety. Psychobiological, a lot of that could be our biofeedback, right? Integrative therapies. There's, I know, a ton that y'all didn't even talk about. Um, there is something called an alpha stim. An alpha stim is kind of like a TENS unit. However, it sends a different type of waves. And honestly, sometimes you can put this thing on and it just like you look weird because you hook it to your ears. And it almost makes you feel intoxicated. It's super cool. Health teaching. Is our patient eating? Are they eating appropriately? Right? Or are they just eating fast food for every meal? Right? How much caffeine are they drinking? How much water are they drinking? Are they getting exercise? And again, exercise does not in any way, shape, or form have to be like go do CrossFit, 20 minutes a day of just walking, even, right? We have to do that health promotion. When we look at, right, primary, secondary, tertiary interventions, that primary prevention, teaching, getting in, talking about coping skills, staying healthy is going to work better in the long run. Advanced practice interventions are going to be a lot of what your nurse practitioner, your PA, your psychiatrist, psychologist, social workers are going to do, right? Cognitive therapy, we are going to change a negative thought into a positive thought. Behavioral therapy, right? In behavioral therapy, we don't necessarily care why our patient's anxious. We don't care why you don't like spiders. We're just looking to change the behavior. So just teaching relaxation techniques, right? Systemic desensitization is that I'm going to show you a picture of a spider. I'm going to show you like a cute little fluffy spider. We're going to watch a movie about spider and slowly work our way up. You see systemic desensitization in that phobia. Flooding, I am going to lock you in a room filled with spiders. And all at once, you're just going to get all of the spiders. And eventually, right, maybe they're just daddy long legs, right? They're not harmful. You're just going to kind of get through it. Just you're locked in the room. You have no choice but to start liking spiders. Thought stopping. If we have a negative thought, we're just going to stop it. Nope, go away. I'm not going to think this negative thought. Cognitive behavioral therapy ties together cognitive therapy and behavioral therapy. And cognitive behavioral therapy is honestly, in a lot of ways, our gold standard, right? It's what we are going to do for most of our patients. We are going to try to look at that negative thought, and then we're going to try to look at the behavior that goes associated with it. So we kind of tie it all together. Like, what is that activating scenario that is causing the stress? What are your thoughts and what are your behaviors? And we tie it all together. It is kind of, if we're going to think about CBT as anything, we are rewiring the brain to have healthy, realistic thoughts. Evaluation of the patient. What is the anxiety level? Just like we ask our our med surg patient on a scale of 1 to 10, how bad is your pain? I ask my psych patients on a scale of 0 to 10, how bad is your anxiety? And a lot of times I want to know where they think their baseline anxiety is. Because if they tell me their baseline anxiety is a 7 and today their anxiety is a 7, I'm like, okay, right? We are at baseline. I want to, one, keep it at the 7 and slowly work on helping them keep it down. Does the patient recognize symptoms of anxiety related? If you have a patient who is, pulling out their hair for trichotillomania, do they think it is what it is, or do they realize there is an anxiety component? What signs and symptoms does the patient show? Do they have the obsessions? Do they have the phobias? Right? Are they more or less frequent with that obsessive compulsive disorder? Right? The thought might still be there, but now they're washing their hands 5 times instead of 10. It is less frequent. Or is the thought less stressful? Can they use the new behaviors that we're teaching them, right? I said I'm not a meditation person. It just doesn't, I don't like quiet. It doesn't work for me. But if we're like, hey, go do this activity, and they do this activity and they're like, wow, it made me feel better. Relationships, interpersonal relationships is always a huge one in psych. Can they maintain satisfying? And when we look at satisfying, it's hard because it's not going to be our definition, it's going to be their definition. Can they do self care activities? If you have generalized anxiety disorder and you are awake all night, right? And in generalized anxiety disorder, we kind of see what I would call snowballing. I don't know if you've ever heard the term before. You start with one thought, I'm failed a test. And I failed the test, and maybe you got 72, so we didn't really even fail. And I'm going to get kicked out of nursing school. I'm not going to be able to find a job. My husband's going to divorce me. I'm going to have to be living in my car. And then what if my car breaks down? Then I'm going to be living on the street. And then next thing you know, I'm going to be like homeless in downtown Austin. And there's a serial killer in Austin. So next thing you know, someone's going to be pulling my body out of Lady Bird Johnson Lake. And we go from like one little tiny worry to like, I am going to be dead. Can the patient assume their usual roles? If we have a parent and they are struggling with such anxiety, they're struggling to care for their kids. We have to look at that. How are they doing with their life? Quality improvement, the clinical global impression severity scale is something we can do that help look at kind of an objective number. 80% of patients with anxiety disorders are monitored every 6 weeks with this scale. Right? And again, after 6 months of treatment, 50% of patients with severe anxiety disorders will score less. Kind of what we want to see. That would be our goal. And it's just one way, and I can post what the CGIS is. It's just one way to monitor progress. But again, then we'd have to assume that all of our patients are going to therapy and doing what they need to do. And that's not always the case. So we are at our stopping point of going for an hour. So not bad with an hour and 6. Remember, complete that table and get it submitted by Friday to get your credit. And then in an announcement, I will post a bunch of short little videos and clips that can help re-explain some of the stuff we talked about tonight. In Friday's lecture, we'll have a few minutes to touch base on this stuff, answer any questions, go over that defense mechanism worksheet. So do that too, because that can really help you start to recognize what the different defense mechanisms are. And again, if you have any questions, don't hesitate. Don't wait till Friday. Feel free to shoot me like an email or a Canvas message, and I will get back to y'all. Hope y'all have fun at the Capitol, and I will see y'all on Friday.